Olalekan. So as I said earlier, I'm one of the co-authors for this paper. So we are happy to be part of the team to present for the 4th International Conference on Internet of Things and Embedded System. So thank you for the platform. So we have a group of people collectively come together to have this research as one of the things that we find it needful for us to do some findings around the healthcare disparity in the United States. And we are able to make our hand dirty in terms of getting the right data and the information we need for this. And that is why we are part of this today. And the topic here is just basically talking about how we make use of the available data and how to come up with the idea of what is the status of the healthcare disparity as it is currently in the United States. So that is the idea that we hope come together to bring up about this topic. And the topic is a comprehensive data-driven analysis on healthcare disparity in the United States. So I will be running you through the following content as it display on the screen. I will take a bit time to explain some part of it, which we embedded in the research. So, basically, the first thing that comes to mind is to talk about the healthcare itself and how the disparity come into play, basically. So, so when we are researching into this, it is very prominent for us to actually know what are we talking about in terms of the disparity and the healthcare itself. So in general, a healthcare disparity is a difference between population groups in the way they assess or experience and receive healthcare, basically. And this cut across different races and ethnicity. And so there are some factors that actually influences this healthcare disparity. Major part of it that we also mentioned in the research or in this paper are the socioeconomic factor, environmental factor, and other major disadvantages that we can also talk about, and some which are also explored in this report. So basically, we be touch base on some key part of the health disparity that we have in United States, basically. So as the introduction persists, we try as much as possible to review some other content, which has to do with the description we give to the health disparity, basically, and the capacity at which we reach optimal health among the particular population group in the United States. So this is a circle that actually, this was as a result of the caption that we have as a circle of health disparity that compound one another. It's often called social determinants of health from a science of Georgia. So this display of the circle of environmental health disparities cut across what are the things that we majorly look at when we talk about the health disparity. We, as mentioned, like the one that started with, I mentioned earlier, which is the social economic factor. These are the consign of how education comes into play, how people are able to use their income to achieve their health maintenance and the like. So it's all cut across and embedded in the social and economic. And also we have compounding factor, which as a result of the social determinants and the social capital that every individual earn on a daily basis. And some other information like residential, environmental impact, and health risk factor itself. There are some other major health risks that we can also talk about cardiovascular disease. How do you take care of these, having health insurance and the like. So there is a lot of information that's cut across when we are looking at the health disparity and what we basically mean by saying a circle of environmental factor that might resulted into having the health disparity, basically. So this is a circle that you can actually have a summary of what we are actually referring to as the health disparity. And furthermore, we tend to look into the literature review, which has to do with the previous work that has been done with some major studies. So, so over the time, we look at some studies, some reports that has been made concerning the health disparity in the United States. So there's one of the studies that majorly indicated the Black individuals with end stage of some diseases, and we found out that are less likely to receive some kind of dialysis and kidney transplantation. And this is as a result of what we talk about when we are categorizing the races of the Black and the white. And this has to do with how the study majorly classify into the Black and Hispanic patient experiencing some health diseases like a bone fracture in some hospital emergency. And some of the research were able to justify that there are some of the white patients receive more health attention than the Black one. So they are, in this research, they are just trying to categorize how the disparity comes into play. And I think things has changed now in terms of how this revolve. But over the time or before now, things has been like it has to be based on who to attend to at a point in time. And this is one of the reasons, one of the things that we are trying to adjust with and see how the data evolve over time in terms of how the segregation work with individual. So in response to some of the reports that we have, the healthcare disparity, we look at the Congress in 1999, which requested that the Institute of Medicine, which is now known as National Academic of Science and Engineering and Medicine, they actually assess disparity in the types of types and quality of healthcare received by the racial and ethnic minority and even non-minority in the United States. So this is just to come up with the idea of the previous study that has been done when we are talking about the Black and the Hispanic patients experiencing some health status. So these are the things that they have to look into, and this come up in the Congress in that 1999. Also, the committee conclusion was that racial and ethnic healthcare disparity are consistently observed across a range of illness and healthcare service. So it cut across different socioeconomic and also some other things that we can look at that might be a kind of, if you are coming from a Black American side or coming from a white side, it is paramount to know the genesis of how the earth is revolved, what is prominent in this part and what is prominent in the other part. So these are the things they look at, and this person, Nelson, 2002, which one of the research paper that we come out to understand the linkage in terms of socioeconomic differences and as well the decrease in their health status. So some of this research do their normal findings and demonstrate a lot of health, race, and ethnicity that can be attributed to a combination of factors, which include some psychological psychological elements and also some physio-social elements. and some other cultural distinction that we also are going to review. So all these are the things that we come across together for us to come up with the idea of running a data that's actually fitting for different category of ethnicity, gender, and the age itself, which is what we actually build on while running the analysis for this research. So another question that comes into play is to basically ask ourselves the question of at what level of disparity or what level of disparity in healthcare are we willing to tolerate? So the United States leads the world in healthcare innovation, which is well known to everyone, but they are tragically dead last when it comes to when we compare them to other high-income country when it comes to keeping the citizen healthy. So I think the only level of the richest nation in the world or guarantee every resident is a trip to the emergency room. And so that is so common in terms of what we experience in United States here. So most people will probably agree that treating someone after they become sick enough, maybe that means that is giving them an idea of the person need an emergency care, which is not the best way to deliver healthcare, particularly when as many as a quarter of emergency room visit may be preventable. So emergency care is very expensive, if you ask me, and and that has been a kind of what has been overused, and it's one of the reasons our per capita healthcare cost in the United States exceed about $10,000, and we are where more other countries they can spend half of that same amount for similar or better outcome. So these are the questions that we need to know what is the status of how we can afford the available health care that we have in the country majorly. So we then conclude to come up with the idea of how do we make use of the data we have, and how do we make reference to all these concern that we have in health disparity. So starting with the diagram I have here, which is like a Venn diagram that is showing moving from the structural inequality that we talk about in terms of the ethnicity and of what we experience as health disparity in the United States. So looking at the structural inequality, and as well, how does that related to the public health, and what are the data we are trying to get out of that? All these come together, we see where the health disparity position in terms of there is no way we want to disjoint the structural part of the inequality that we've been experiencing over time, and also the public health that is made available to us. So how do we marry this together? So they have connection in terms of we can't let out one for another. So this intersection that happen between them, and there is a data that need to speak over time to this. So that is where we are coming up with in our research in terms of the data-driven intervention that we are trying to achieve when it comes to the public health, and what data do we have currently to justify how to improve how we eliminate the health disparity that has been evolved in many decades currently. So reviewing major part of the data we have, we are able to look at the age part of the disparity when we come to looking at the different age as we have on the slide here, we can see, and this is actually across so many years, but I think there's other charts that show the year based on the age of the people that we review the data here in the United States. So in 2017, basically, when we examined this particular data, we are able to see that the top 5% of America in terms of healthcare healthcare spending, it become evidence that the majority of these individuals were age 65, which is right here, the green bar that is showing here, and that's 65 years older, and specifically near 42% of them fell into that age bracket, which looking at their spending basically in terms of the healthcare. So the data offer a kind of glimpse into how individuals are distributed across age group in the United States, considering their position within the top percentile of healthcare spending. So these are just for us to understand how much do you have to take care of your health, and in what capacity of your status, maybe because you are in this category of age, maybe you are a beneficiary of some health benefits and also some kind of things that work for you. Maybe you have enjoying your retirement plan and able to use that to avoid some status in your health. So this is one of the age we look at. We also look at the gender and also the ethnicity. So for the gender, we are able to have the research that we actually capture for 1992 to 2006, basically, where they have this report. And the data actually cut across 2010 to 2019. And then across the data, when we have on the gender side of in 2014, the average life expectancy that we can infer at birth was about 81.2%, as shown here. So for that is for the female. If you are looking at that, is for the woman there, and 76.4 years for the men. And this is over the decades of what has been measured, because if you look at from 2004 to 2014, this has revolved over time without changing. So the life expectancy gap between men and women decreased from 5 years to say 4.5 years. Why the narrowing of this life expectancy gap might initially appear as a positive trend. So it's in fact a concerning development that we actually infer from the data. So also for the ethnicity, so this is majorly we'll be talking about the race itself in terms of when we look at the ethnicity part of the data, and we look at how that has been coming up from a year to 2010 for major Hispanic and non-Hispanic. And for the Hispanic, we have a kind of a very decrease over the time as what we experience as one of the things that happen, that there have to be a kind of a segregation between the Black and the Hispanic, as we mentioned in the literature earlier. So for the analysis, we make use of some part of the data that revolve around the ethnicity group, which happens to be the key factor that we want to look at, where we have major concern of the Hispanic when it comes to their health insurance and the like. So we look at the data and we are able to come up with some of the data that we can make use of in terms of making a reference or inference to the outcome of the data. So we look at the data that's shown the Hispanic in terms of their rate of delivery. And so for the one we have here in 2000 and for the one we have for the Hispanic here, which we have non-Hispanic and non-Hispanic white, we have Asian or Pacific. This is non-Hispanic Asian and Pacific Highlander. And we have also other non-Hispanic white and non-Hispanic black. So we're able to use this data to measure how this has been, because this is one of the historical data that we come out of the healthcare research and quality healthcare cost and utilization. So in 2019, majorly for this report, the incidence of severe maternal morbidity during the delivery was significantly high among the non-Hispanic black, so which is showing on this yellow. So we are able to find out that this is so prominent among the non-Hispanic black. And also, as we compare it to non-Hispanic white, individual with 87%, 80% increase as illustrated there, has been show a further understanding of how the race part of disparity when it comes to how the healthcare or the healthcare community attends to individual when it comes to their ethnicity. So and we furthermore in that 2019, the rate of severe maternal morbidity during delivery was high for the individual as compared to when we are comparing the non-Hispanic white and the black. So it's generally on the high side also, when we have about 8.2 per 1,000 delivery. So which is for the non-Hispanic API. So so generally, this is just to give us an overview of how this has been over the time and how the delivery from the healthcare part of it to individual in this ethnic part revolve. And so I think this has to do with the likelihood of what their health insurance is all about. And that is one of the major things that we able to came up with in terms of the generality of the data, trying to tell us that majorly most of the people without the health insurance or with or without the health insurance still will give us a room to experience more of this healthcare disparity. I think having the health insurance will do more to resolve or to curb the habit of the racist part of the experiences we have over time. And I think that is one of the key factors that we are able to come up with as our conclusion. And if you don't have the health insurance majorly, that means that should be a key factor that you still have to be part of the cohort of people that will be experiencing this same health disparity we talk about. So we tend to conclude that in the United States for the health disparity, there are some significant things that we have to represent in terms of the primary effect of the socioeconomic advantage and how some other group can benefit from this. So the existence of this disparity can be ascribed to an intricate interaction of elements like race, ethnicity, and economy, socioeconomic status, majorly for the gender, age and geographical location that we look at in this research. We also look at, when we are talking about the life expectancy disparity, which exists between the racial group with the non-Hispanic individual and also the non-Hispanic white and the Black that we look at generally. So these are the things that we came up with, but for the further study, we have some kind of how majorly can we eradicate this in terms of even if you have an insight into what caused the disparity. So what are the things to do to eliminate ed disparity majorly? So I have some highlights here that happens to be the major what we can use as basis to eradicate the ed disparity. So we have the ed outcome. The ed outcome will be very widely based on the race that we already have a justification for, that everybody must be on the same page. And so disparity are often linked to social, economic, and environmental disadvantage. So it depends on where you find yourself. You are not, if you are from other country that visited United States of America, you just have to find a way of getting your health insurance into place before you can have a full benefit of what the health is all about. It is when you involve in the health element of it that you majorly understand how important all these parameters are to be in place for use. So also for the health disparity are not intraceable and can be reduced or eliminated with focus and commitment and effort that we can adopt over the time. So I think that's majorly the summary of what we have in our research. So for more detail that we don't want to embed it in the slide, and for the data we have, so these are the references that we make use of in terms of working and building on the existing work. And also that would be the final summary of my presentation. Thank you very much.